Hi, everyone. My name is Katherine Bienassis, and I am a health policy analyst with the OECD. And a big thank you to the German Coalition for Patient Safety for inviting us to present today. We're very sad not to be able to participate in today's meeting in person, but are very happy to be able to share some of this information on international performance on patient safety work in this area being conducted by the OECD, with a specific focus on indicators related to patient safety culture. So first, some very high-level background about OECD work on patient safety. The OECD has been working in this area for the last 10 years, looking to help develop internationally comparable patient safety indicators between OECD countries to allow comparisons of performance of health systems in terms of maintaining safe environments for patients. Why is OECD working in this area? Well, the first fact is that this is an extremely common issue. An average of 1 in 10 hospitalizations in high-income countries result in a safety failure or adverse event. And the cost of this are considerable for OECD countries. So estimates from the OECD suggest that as much as 15% of hospital activity and expenditure could be directly attributed to patient harm experienced over the course of their care. As such, the OECD has been collecting a portfolio of indicators that assess patient safety in the hospital setting, as well as in the primary care setting, looking at safe prescribing, and then also a number of indicators in long-term care. And then in the most recent round of data collection, we have had 2 pilots looking to create internationally comparable indicators in the areas of patient safety culture and in patient reports of safety incidents. Before I get into the work on patient safety culture, which will be the main focus of my talk, I do want to highlight some of the ongoing work that the OECD is conducting on patient safety policy. We've had a number of recent reports over the previous years looking at the economics of patient safety. This has been a series that has been supported by the German government, and so we're very grateful for the support to help us conduct this work. And as such, we've been working on a series of papers looking at the economics of patient safety at the national level, focusing on primary and ambulatory care. We have a report on the economics of patient safety in long-term care, and then safety in the workplace, and then a report that's currently underway looking at the economics of medication safety. And the reports that I have in bold here are available translated into German, or will be for the italics ones. And all of these reports are accessible on the OECD website. Also for reference is the recent reports that have been published on patient safety on other topics, including system governance for improving patient safety, and then reports assessing safety culture. So a bit of background on the work on patient safety culture. This is a project that's been going on for the last several years. And essentially, we're looking at how countries quantify health workers' assessments of individual and organizational behavior, looking at shared beliefs and values, which minimize harm that could result in the process of care delivery. So this is essentially looking at how healthcare workers perceive these values in their work environments, and this is quantified through systematic surveys. Initial scoping work to assess the status of measurement of patient safety culture was conducted in 2019. And during this work, we found that 20 of 24 surveyed OECD countries currently use a patient safety culture assessment tool in their healthcare system, and that this is a major policy priority where 18 of the countries plan to initiate or expand work on this topic in the future. And while this is only one perspective on safety, it's an important part of the safety measurement constellation. So by adding measures of patient safety culture and including them with metrics of traditional patient safety indicators, which may come from administrative data, patient-reported experiences of safety coming directly from patients, health outcomes indicators also coming from administrative data or EHR data, and these indicators on the assessment of the work environment from the care providers. We hope that this can give a more full picture of the actual status of safety in OECD countries. So moving forward from the work to assess the state of measurement, the OECD supported the creation of a working group where countries work together to assess and actually benchmark using the tools that were currently being used to assess patient safety culture in their countries. So the expert group has 22 countries participating, and the group agreed to collect information on the percent positive response rates using the hospital survey on patient safety culture. This is a tool developed by AHRQ, the Agency for Healthcare Research and Quality in the United States, where the majority of countries are currently using this tool, or the SAQ, the Safety Attitudes Questionnaire, which was the second most commonly used tool. Our data collection included the assessment of workers in the hospital setting, including psychiatric settings. And then we asked for data stratification by health worker type. So for example, whether the reporting staff member is a physician, a nurse, another clinical staff, non-clinical staff, or management. And ultimately, we received 42 data submissions spanning the last 15 years from 16 countries. So the idea of this initial work was to really get us a comprehensive picture, if possible, of the different measurements and their results, and use this as a starting point for further harmonization and benchmarking further down the road. So we were very happy to be able to publish the first results of this work in Health at a Glance 2021. And here we reported on 2 domains of patient safety culture that had been identified as being particular priorities for the working group. And here we found that on average across OECD countries for which there was data, fewer than half of the hospital staff surveyed thought that the quality of handoffs and transitions were appropriate and sufficient. And what that means is that the staff members believed that important patient care information is transferred between hospital units and during shift changes. This was a particular area where country experts felt that there was additional policy work that could be used and conducted to improve the quality of these handovers and ensure that patient information is appropriately communicated over the course of a patient's care. Another indicator that we reported, like handoffs and transitions, was overall perceptions of patient safety. And here we found that just over half of health workers thought that they had an overall positive perception of patient safety, meaning that the staff think that the procedures and systems at their workplace are good at preventing errors and that there's a lack of patient safety problems. And so this is a pretty startling figure showing that almost half of workers feel that their workplace is not necessarily providing a safe environment for the patients that are there. Here's a few other indicators that I will share. These are all reported using the AHRQ tool. Ultimately, we received just 1 data submission using the SAQ. And the ARC tool includes 12 domains, all of which are included in the working paper that's available on the OECD website. But again, I'll just highlight a few of the key findings here today. So next is staffing among health workers. This is a really important domain that we've seen only growing in increasing importance with the COVID crisis, where many health systems have seen significant staffing shortages. And obviously this has downstream effects for the safety of patients. Here we see, and this is data coming from before the COVID pandemic, that on average, only 40% of hospital staff think that they have the appropriate staffing levels at their workplace to ensure patient safety. And so this means that more than half think that staffing levels are too low to ensure safe care. And here you can see some variation, but in almost all countries surveyed, this figure was less than half, with the exception of the Netherlands and the United States, where the figure is still either between, the figure is still below 70%. Another key area relates to leadership and how the leadership of hospital systems support patient safety and enable their workers to address and have the appropriate resources to solve patient safety issues. Here we see that half of workers believe that their hospital management actually helps provide a climate that promotes patient safety and thinks that patient safety is a top priority. But again, here we see that this means that on average, half of surveyed workers don't think that this is a top priority among their workplace's management. So here is another item to report that comes from a different data source. So this is findings from our work on patient-reported safety indicators. And this shows that many patients, a significant number of patients in both the general population and those hospitalized, report that a medical mistake was made during their treatment or care from 2020 or the nearest year. And so here we see that in a number of countries, more than 5% of patients experienced a medical mistake in the previous year, and the same goes for hospitalized patients. And I just show this figure because this information was reported together with the information on patient safety culture to show how information from other data sources aside from hospital administrative data could be used to help provide more insights as to the rates of safety events and the status of these occurrences. So where will we go next in this work? There's a few areas. First is that there are proposals within the expert group to collect additional information to provide more context in terms of the patient safety culture measurement. This includes information in regards to hospital size, the type of hospital, the relative percentage of respondents from different staffing categories. And then probably the most importantly that there was a lot of discussion about is the fact that culture is not a national concept. It's really something that exists within hospitals and more specifically within the wards of hospitals. So how we can calculate these indicators in a way that shows more the performance at the hospital or unit level. So we've had some proposals on this from the members of the expert group, and we're looking into how we can incorporate this kind of assessment to give a picture more about the performance on these indicators and domains at the national level, reporting on the status at the hospital or unit level. For example, the percentage of units that report a positive impression of a patient safety domain above a certain threshold. There's also a lot of interest on exploring sites beyond the hospital. So for example, looking at patient safety culture in primary and long-term care. Here from COVID, we've seen that this is extremely important. And there are a number of comprehensive surveys being conducted in these settings currently in OECD countries. And then there's also some key linkages that can be made with work such as health worker safety, resilience, and patient-reported experiences of safety. I'll just add that one final issue that we're thinking about is that the standardized survey that we used for this initial benchmarking exercise, there's a new version of it that came out last year. And a number of countries are incorporating this tool into their ongoing data collections. And there are some differences in terms of the structure of the domains, the items, and also the performance of different items. And so we'll need to look into this and see how we report on the patient safety indicators using this tool in the future, considering that there are two different versions of the tool in use. So I have the link here to the full report, and please welcome you to take a look. So this is the end of my presentation. Thank you for your attention and for the invitation to present today. We're very happy to share this work on safety culture. And please do not hesitate to contact me if there's any questions or information that you'd like to share. And have a wonderful rest of your meeting. I hope it's a productive one. Thank you very much.